and welcome to another night at CEC discussing the valvular heart disease. We have an interesting webinar today discussing the imaging and trials of the aortic stenosis treatment, the TAVR population imaging and case scenarios. We will have some interesting lectures discussing the latest data about treatment of patients with aortic stenosis using the TAVR technique in moderate and low risk patients by my dear friend and CEC co-member, Dr. Muhammad Zahran, Associate Professor of Cardiology in Shams University. Then we will have a very, very interesting session about the role of echo and CT imaging in periprocedural evaluation of TAVR by Dr. Ozkan, cardiology consultant from Turkey. And then a TAVR case in a critically ill patient by my dear friend, Dr. Karim Mahmoud, lecturer of cardiology, Cairo University. We have an interesting panelists, and we hope to deliver you high quality science. And let's begin. Dr. Muhammad.
So good night, our dear viewers from all over the world. I'm glad and happy to be with you tonight. I will show you a very short lecture about extending the TAVR population to the low surgical risk patients, which was updated in the ACC of 2019. Of course, the heart valve team or the heart team includes the cardiologists and the cardiac surgeons. And we should never think that one modality of therapy will deny the alternative modalities. Actually, we are all cardiologists, cardiac surgeons, anesthesiologists, clinical cardiologists, ICU doctors. All of us are serving the patients to give him the best option for his best sake regarding this severe critical condition. So actually, the previous TAVR studies have shown that the TAVR was superior to the medical therapy in the extreme risk patients in the first published trials, and for the inoperable patients also. And also the next subsequent trials showed that it was not inferior to surgery in the high and intermediate surgical risk patients. And over the past decade, technology enhancements and procedural refinements have reduced the complications and improved the clinical outcomes after the TAVR procedure, such that the majority of the aortic stenosis patients treated with surgery that have low surgical risk profiles, and TAVR versus surgery in such profile of patients was not yet investigated until we got the two publications in 2019. So we got the Partner 3 and the Evolute low risk trials. Both of them were published in the New England Journal of Medicine. And this is the pathway that we previously had. In 2010, we got the TAVR procedure for aortic stenosis patients who were denied by surgery. And in 2011, we got the transcatheter versus surgical aortic valve replacement in the high surgical risk patients. And in 2016, we got the transcatheter versus surgical aortic valve replacement in the intermediate risk patients. So the remaining quadrant for investigation was actually the low-risk surgical patients. So this is what was new in the ACC in 2019. We got the two publications in the New England Journal of Medicine, the one involving the balloon expandable valve in the low-risk patients, the Partner 3 trial, and the one involving the self-expandable valve in the low-risk patient, the Evolute low-risk trial. So let's go rapidly and swiftly through these two different trials. The Partner 3, of course, trial was done in 71 sites, and it was comparing the safety and effectiveness of the SAPIEN 3 TAVR system versus the conventional SAVR or aortic valve replacement with severe, of course, symptomatic aortic stenosis, but are at low surgical risk. The study, of course, involved number one, to be assessed by the heart team to have a low risk by STS less than 4%. They had nearly 1,000 patients that were randomized to TAVR by the SAPIEN 3 heart valve, balloon expandable valve, and the surgery using the surgical bioprosthetic valve. And the patients were followed up at 1 month, 6 months, and annually for an extended follow-up for the next 10 years. The primary endpoint was the composite of the all-cause mortality, stroke, cardiovascular rehospitalization at 1 year post-procedure. It included 71 sites, 65 sites in the United States, 1 site in Canada, 1 site in Australia, 1 site in New Zealand, and 3 sites in Japan. So, of course, it included the patients with severe calcific aortic stenosis as defined by many definitions that will be discussed by Professor Ozkan in the next lecture, and the patients were at a low surgical risk determined by the heart team to have an STS score of less than 4%. Of course, the anatomical exclusion and the clinical exclusion criteria were a lot of factors involving those with low ejection fraction, involving those with inapplicable puncture site for access for the TAVR procedure, or involving sizes that were not available by the current manufacturer, and clinically, of course, the factors that would prohibit the inclusion in either of the two pathways. Of course, the SAPIEN valve went through a pathway of evolution over the past 10 years. The partner one, it was only 2 sizes, and you needed a 22 to 24 French compatibility. For the SAPIEN XT in 2014 and the partner 2, you had 3 different sizes, and the sheath size was reduced from 16 to 20 French, while in the SAPIEN 3, actually, you had 4 different sizes, and you can go down with the axis side up to 14 French sheath. So the study was reviewed, of course, by the heart team, and the baseline and the 30 days assessment and the 3D cardiac imaging that will be showed by Professor Ozkan prior to randomization. And of course, if you need to perform a concomitant PCI or CABG procedure was allowed, and all of the endpoints were properly adjunctated for non-inferiority and for superiority. So the primary endpoint was the composite of the all-cause mortality, all stroke, and cardiovascular hospitalization at 1 year. As I previously said, the primary analysis was non-inferiority, and if it was met, the analysis was extended for superiority. And the analysis was actually as treated population, defined as the all randomized patients in whom the procedure was initiated, with multiple sensitivity analysis for all the different subgroups. We had 1,520 patients, of which 520 were excluded. So we got 1,000 patients at 71 sites and nearly equally distributed between the two groups to be studied. So the TAVR was initiated in 496 patients, the surgery in 454 patients, and interestingly enough, you nearly got a 98.4 successful follow-up at 1 year for the primary endpoint, with a 99.4 follow-up for the TAVR arm and a 97.4 follow-up for the surgery arm. This is a very successful follow-up. The baseline clinical characteristics were matched between the two groups. Nothing was significant. And the baseline echo and CT characteristics were also seen in this table. The procedural and hospital findings, actually. So I want you to focus on variable number 2, the procedural time. And the TAVR was nearly 58.6 minutes, plus minus half an hour. So it was extending between half an hour to 1.5 hours. In the surgery, of course, it was much longer than this. The median ICU stay was 2 days in the TAVR, 3 days in the surgery, which was significant. The median total length of stay was 3 days in the TAVR and 7 days in the surgery, and the discharge 96% in the TAVR, 73% in the surgery, and the concomitant procedures, of course, were much higher in the surgery. So I want you also that the complications in hospital was seen in this table. And then this is the primary endpoint. The primary endpoint occurred in 15% of the patients undergoing the surgery versus 8.5 of those undergoing the TAVR at 1 year. And this was actually started very early by a 9.3 versus 4.2% at 1 month. The composite of death, stroke, and rehospitalization. Of course, this succeeded to meet the P for the non-inferiority, and also this was meeting the p-value for superiority at high significance at both arms. Regarding the all-cause mortality, it was 2.5% versus 1% at 1 year, starting by a 1% versus 0.4% at 1 month. The all-cause stroke, of course, was higher in the CABG, nearly threefold, 3.1 versus 1.2 at 1 year, starting by a 2.4 versus 0.6 at 1 month. The death or disabling stroke was also threefold, 1% in the TAVR, 3% in the surgery. The rehospitalization was 11% in the surgery versus 7.3% in the TAVR. All of this was highly significant, and the primary endpoint sensitivity analysis on the intention to treat, not the as treated, was also 15% in the surgery versus 8.4% in the CABG, which was also significant. As you can see that the subgroup analysis, whatever is the age, sex, STS score, LV ejection fraction, NIHA class, atrial fibrillation, Kansas questionnaire, whatever, you can see that the analysis actually is in favor of the TAVR, as you can see, and this is significantly in favor of the TAVR procedure. The pre-specified secondary endpoints, also the new onset atrial fibrillation, was only 5% in the TAVR. It was nearly 40% in the surgery. The length of hospitalization, as we said, 3 days versus 7 days. All-cause death, the Kansas City questionnaire quality of life score, the death or all stroke as 30 days, the all stroke at 30 days, it was all significantly reduced and better on the TAVR arm. Regarding the bleeding and the new onset left bundle, points number 1 and number 5, it was highly significant with the surgery compared to the TAVR procedure at nearly 25% of the surgical patients versus only 3.6 in the TAVR. The new left bundle was 8% in the surgery versus 22% in the TAVR, and both of them were highly significant. Some may question the efficiency of the valve in reducing the mean gradient. As you can see here, this is the start point. You had a mean gradient of 50 millimeters mercury before you do the procedure, indicating a severe aortic stenosis. And then suddenly you did the procedure. It was dropped to 12.8 in the TAVR, 11.2 millimeters mercury with the surgery. And at 1 year, this was maintained at 11.6 for the surgery and 13.7 millimeter for the TAVR. This was highly significant as a start, but it shows you that both methods are actually effective enough. Of course, the aortic valve area, you started by 0.8, which rising up to 1.7 with the TAVR, 1.8 centimeters square with the surgery, which was maintained at 1 year, because sometimes you ask, is this valve area that I get today, will it be maintained? Well, we have data that it's going to be maintained. Of course, for the paravalvular regurgitation, with it more than moderate, it was non-significant between two groups regarding the surgery or the TAVR, but in the mild, it was actually much better performing with the surgery than with the TAVR. As you know, that what actually has a clinical impact on the patient is the higher paravalvular leak, more than mild. So the moderate and the severe are more important. Of course, the NIHA class, as you can see, is highly significant at 30 days and equally significant at 1 year regarding the NIHA class. The 6-minute walk test was highly significant also at 30 days, equally nearly significant at 1 year, and the Kansas City questionnaire for the quality of life of the patient was also significantly better for the TAVR at 30 days and nearly equal at 1 year. So do we have some study limitations for the partner 3? It was only reflecting a 1-year outcome in 2019 in the ACC. You need, of course, a long-term assessment and plan that they have a 10-year clinical and echo follow-up for all those patients. Of course, you can only apply these results to this population studies. So you excluded the bicuspid aortic valve, the aromatic patients, the non-suitable for transfemoral access, the complex, so on and so forth. So we conclude from the partner 3 that in a population with severe symptomatic aortic stenosis who are at a low surgical risk, the TAVR using the SAPIEN 3 valve compared to surgery successfully and significantly reduced the primary endpoint of death, stroke, or rehospitalization by 46% at 1 year. All of the components of the primary endpoint favored the TAVR at 30 days and at 1 year, and the multiple sensitivity analysis for all the subgroups confirmed the robustness of the primary endpoint findings. The secondary endpoints adjusted for multiple comparisons showed that the TAVR reduced the new onset AF, which was nearly 40% with the surgery, down to 3% with the TAVR. The index hospitalization days, 7 days with the surgery versus 3 days with the TAVR, and the measure of the poor treatment outcome by the Kansas City questionnaire score for the quality of life at 30 days. So the other secondary endpoint analysis also showed the reduced bleeding after TAVR, no difference in the need for new permanent pacemaker regarding this balloon expandable valve, major vascular complications, coronary obstruction, and the significant moderate to severe paravalvular regurgitations. Some secondary endpoints favored surgery, including the reduced new onset left bundle, the reduced mild paravalvular leak, and the lower aortic valve gradient by nearly 2 millimeters between both groups. The TAVR had a more rapid post-procedural improvement in the patient-oriented functional indices, including the NIHA class, the 6-minute walk test, and the Kansas City questionnaire. So this was the result from the balloon expandable valve in 71 different sites, mainly in the United States, Canada, Japan, Australia, New Zealand. So what about the results from the self-expandable, the Evolute low risk trial, which was also published in the New England Journal of Medicine? So they started randomizing the patient in March 2016, and they finished their randomization in 27 November 2018, and they started the endpoint assessment in December 27. 99% was transfemoral access, with 1% for subclavian and direct aortic access, and 3/4 of the valve implanted was the Evolute R valve from Medtronic. So it concluded that in nearly 1,468 patients with severe aortic stenosis who were calculated to have a low preoperative surgical risk, the TAVR with the self-expandable bioprothesis was non-inferior to surgery with respect to the composite endpoint of death or disabling stroke at 24 months. Clinical characteristics were similar as treated and on intention to treat basis, and the primary endpoint, as we said, for non-inferiority, which was met, that the TAVR was non-inferior to the SAVR. It was 6.7% in the surgical group versus 5.3% in the TAVR group. As you can see, all with yellow markings were significantly favoring the TAVR, the disabling stroke, the life-threatening or disabling bleeding, the acute kidney injury, the atrial fibrillation, the all-cause mortality or disabling stroke, And of course, the primary endpoint at 30 days composite safety endpoint, 5.3% in the TAVR versus 10.7% in the SAVR, while the permanent pacemaker implantation marked by blue actually significantly favored the SAVR in nearly 18% versus nearly 6%. So the secondary endpoint, as you can see, all of them met the margin of non-inferiority and also at the margin of superiority. The mean gradient at 12 months was 8.6 with the TAVR versus 11.2 with the SAVR. The mean orifice area was 2.3 with the TAVR versus 2 centimeters square with the SAVR. The Kansas City questionnaire, all was superior actually with the TAVR versus the SAVR, and they excluded that the TAVR with the self-expanding valve was non-inferior to surgery in patients with severe aortic stenosis at low surgical risk. The TAVR showed a better safety and recovery profile than with surgery, with less death, disabling stroke, shorter length of stay of hospital, better quality of life, but the SAVR was better with this specific type of the valve because of the fewer pacemaker implanted and the less residual paravalvular regurgitation at 30 days. At 1 year, both groups had excellent survival. The TAVR showed fewer disabling strokes, heart failure, rehospitalizations, with superior hemodynamics actually manifested by lower gradient and larger calculated estimated orifice areas because this self-expandable valve can offer a larger area actually than the balloon expandable valve. So TAVR may be a preferred strategy to surgery in patients with severe aortic stenosis and at a low risk of surgical mortality. I'm running so fast, and I'll come back again to say that we are all in the same heart teams: cardiologists, interventionalists, imagers, clinical cardiologists, cardiac surgeon, anesthesiologists, ICU specialists. You should never think that one modality of therapy can deny the alternative modalities. We are all shipping on the same ship, and we are all doing the best for our patients' sake. Thank you so much. I will be back to Professor Adel Azmi. I will pass the mic to him. I would like to share his insights about this data. So Professor Adel, you're most welcome now.
Thank you very much, Dr. Zahran, for this elegantly presented data about the advancement of TAVI more and more into the arena of valvular interventions by the interventionist rather by the surgeon. Actually, TAVI is a very interesting arena, and we have all witnessed the sneaking, I would say, courageously but cautiously. Starting from the very high-risk patients, we have all witnessed that. We only did the patients denied from surgeons with very prohibitive high-risk mortality into the moderate, and now we are speaking about the low-risk. I think TAVI is one of the most booming and advancing fields for interventional cardiologists. Balloon mitral valvotomy, which was the first one, I think we started also with very high risk, and now it's an everyday practice for each and every one with mitral stenosis, leaving only for surgery the double valve or severely calcific ones. I think TAVI have also superseded the ASD closure devices, the mitra clips. Even now the tricuspid is not gaining such reputation. Very elegant data, and now we are non-inferior. Everybody is sure about this, and now you are even getting more and more by saying that this might be even superior. So I have nothing to say. I have witnessed this in our center. We have also ran the same curve. When the first TAVI was attended by around 15 people, surgical team was there, OR was stopped as a rescue. And now it is done for moderate and low risk by our colleagues, and it's becoming yes, 1 or 2 cases per week. It's more or less becoming routine. Thank you for the elegant presentation. And I think the next speaker is Dr. Ozkan. She is one of the international renowned figures in non-invasive imaging, which is a very essential pre-procedural step, determining the anatomy, determining the access site, determining the type of the valve. So please, I think we will enjoy her widespread expertise in that field. Please, Dr. Ozkan.
Hello, good evening, everyone. My name is Ozkan. I'm from Turkey, Istanbul, and I currently work at Memorial Bahçelievler Hospital. And as you know, I'm a multimodality imaging specialist, and I enjoy it a lot. And I want to thank the Cardiology Education channel for inviting me for the second time. I really enjoy. And today we are going to speak about preprocedural imaging in TAVR procedure. We all know that it's not something new. It's not a new idea. It has started in 1980s, but the first in-man implantation was performed by Dr. Alain Cribier in Rouen in France in 2002. And afterwards, there has been different brands in the field, like Direct Flow, Lotus, Portico, and Santera. But you know, at the end, now we have Medtronic and Cepheid, and we mainly use those two valves. And we all know that imaging is one of the most important parts of this procedure, and you know, every time, always, patient is in the center for us for all procedures, and also in the TAVI procedure. And we want to use multimodality imaging, but we don't know in which patient, which modality we can use, because all imaging modalities have some advantages and some disadvantages. And sometimes we use only one imaging method, whereas sometimes we use all three of them. But our aim is to provide the maximum benefit to the patient with the least harm, of course. I think most of you know my professor. He is Professor Ömer Göktekin. I'm working with him, and I'm really very happy to work with him because it's a teamwork. For an imaging person like me, it's really important to have a good interventional cardiologist and to speak the same language. And you know, an imaging person, an imaging guy, always helps before, during, and after the procedure. We have different conversations, of course. Pre-procedural conversations are generally, he asks me, I have heard a murmur, and is it really an aortic stenosis? Or, this patient has an aortic stenosis, let's plan a cardiac CT, or, we have a TAVI candidate, and let's do a 3D echocardiography because the patient has a kidney failure, so we cannot do a CT. Or just before the procedure, he asks me, how is the valve size? Which access site shall we use? Or is there any particular precaution that I have to take? Or, can you please check the pericardial effusion just now before the procedure for the last time, because it's really very important to check it for the last time before the procedure. And is there any accompanying aortic regurgitation? This is also very important. I will speak about all of those things. And intraoperatively, the most important thing is hypotension. Why do we have hypotension? Let's check it with echo. And after the procedure finishes, we check for the paravalvular regurgitation and, of course, for the post-procedural gradient. And after, for example, 1 to 3 months, 6 months, 1 year, I think the best part is this one, because the ejection fraction is most of the time getting better. Systolic pulmonary artery pressure is going down. But sometimes, of course, we have also some problems. The gradient, mean gradient may increase. Why is it increasing? Is there a degeneration, or is there a thrombus, or what is that? And or mismatch, or what's that? And is the paravalvular leak getting better or worsening? Or I think one of the worst scenarios would be fever. If the patient has a fever, especially nowadays with the prosthetic valve like TAVR valve, of course, we have to be asking to ourselves about infective endocarditis, or in today's world, it could be also something like COVID. So let's start with the basic stuff. On the here on the first line on the left upper side, you can see a very basic parasternal long axis view with a calcified aortic valve. You can appreciate that it's opening hardly, and you can see here the short axis view. Here the aortic valve area is 0.4 centimeters square. It's when it is less than 1 centimeter square, then it's severe aortic stenosis. And you can appreciate also the calcification here. And this is another case, and you can see the short axis and the long axis view at the same time, and the color Doppler as well. And for the aortic valve area calculation, this is very important. I will speak about that a bit in the following slides as well. Now you can see here the alignment of our cursor is very important. We have to be as perpendicular as much as we can, because otherwise it can be underestimated. So for me, it really takes at least 10 minutes to be sure if it is really the correct sizing or if I'm underestimating. It's very important, especially if I see the valve is opening hardly, but the mean gradient is less than 40. So I'm hardly convinced, I can say, and sometimes it takes more than 1 hour for an aortic stenosis patient. This is very important. Always we have to be aware of the risk of underestimation. So of course, this is important, and the other one is the LVOT gradient, and we use the VTIs of those two flows, and we put both of them into the formula. This is the Bernoulli equation and continuity equation. And for the aortic valve area, we also need the diameter of the LVOT diameter we also need. And for the LVOT diameter, it's generally recommended to go below the annulus, 5 to 10 millimeters below the annulus, like that. And of course, we use 2D parasternal long axis view with the zoom mode in the mid-systolic phase, like that. And we put everything into the formula and we calculate the aortic valve area. And sometimes we use aortic valve area index. It is especially for small body size or large body size, but large body size doesn't mean obese patients. We generally don't want to calculate this aortic valve area index in obese patients. It's not recommended. But for small bodies and large bodies, like let's say a basketball player, a large body size, we use aortic valve area index. And in 2017, there was a paper from Dr. Rebecca Hahn and Dr. Philip Fibarot in Journal of the American Society of Echocardiography in October 2017. And generally it's recommended to calculate, to measure the LVOT diameter 5 to 10 millimeter below the aortic annulus. But according to Dr. Hahn and Pibarot, they were advocating to measure the aortic annulus not 5 to 10 millimeters below the annulus, just below the annulus, because they were thinking, they think that it is not the same shape in the distance of 10 millimeters, because generally those patients have those patients with severe aortic stenosis have severe left ventricle hypertrophy, especially sigmoid septum, which changes the annulus shape, and which may give a wrong decision at the end. So they were not supporting that 5 to 10 millimeters idea. But there was a reply from the authors, from Dr. Helmut Baumgartner and Judy Hung, and they were saying it's all about the laminar LVOT velocity. If we can they were saying when a laminar LVOT velocity profile can be obtained at the aortic annulus, measurement of the LVOT diameter at the level of the aortic annulus is preferred. But generally it's not. That's why we prefer to go below the annulus 5 to 10 millimeters. Well, I will not go into details for the grading of aortic stenosis, but of course, what are the criteria for severe aortic stenosis? Those are the very basic things, but important things. I just wanted to remind, because we are talking about TAVR procedure and it's all about aortic stenosis and severe aortic stenosis. So if our aortic jet velocity is more than 4 meters per second, if our mean gradient is more than 40 millimeters of mercury, and if our aortic valve area is less than 1 centimeter square, or if our aortic valve area index is less than 0.6 centimeters square per meter square, I told about that. If the body is very small or large, we don't use that for the obese patients. And if the velocity ratio is, if the DVI velocity ratio is less than 0.25, and we calculate that by dividing VTI of LVOT into aortic valve 1. So if it is less than 0.225, then it also supports severe aortic stenosis. And sometimes we have different situations, of course. It's not always like that. And most of the time, it's not like that, I can say. And sometimes Vmax is more than 4 meters per second. And we think that it must be severe aortic stenosis. But when we calculate, the aortic valve area is not less than 1 centimeter square. It's more than 1 centimeter square. And what's happening there? Maybe it's a high output state. It could be. And we have to keep in mind moderate to severe accompanying aortic regurgitation, which is most of the time the case, because if it's a degenerative valve, most of the time moderate to severe aortic regurgitation is together with aortic stenosis. So if we have that, it can be like that as well. And if the person has a large body size, it can be also like that. So sometimes Vmax is less than 4 meters per second, but the aortic valve area is less than 1 centimeter square. So we think that it is a severe aortic stenosis, but the Vmax is not more than 4. So what's happening? What are the likely causes? Most of the time it's low cardiac output, but of course it could be small body size. And we have to keep in mind severe accompanying mitral regurgitation as well. So this is an entity which is known just little. So I just wanted to include this slide in my presentation as well. It's about impedance, and let's go step by step. Impedance is a measure of total opposition to a flow, and it's calculated as systolic blood pressure divided into stroke volume index. And in patients with aortic stenosis, if left ventricle in our patient group, meaning in our patient group, left ventricle pressure burden is the sum of systolic blood pressure and aortic valve pressure gradient. And in this situation, we talk about valvular arterial impedance. We calculate this one in the aortic stenosis patient group. It is ZVA. And for the ZVA, the formula is systolic blood pressure plus mean pressure gradient. We sum up both of them and we divide it into stroke volume index. And studies have shown that if the ZVA is more than 3.5 and 4.5, it indicates moderate and severe impedance, respectively. And in patients with hypertension, ZVA is a better severity marker for aortic stenosis if the patient has a hypertension in aortic stenosis patients. It's a better severity marker than aortic valve velocity, mean gradient, aortic valve area, and it is a better predictor for left ventricle dysfunction and clinical outcome. And in patients with aortic stenosis, the baseline ZVA is more than 3.5 was associated with a poor clinical outcome compared to those with ZVA less than 3.5. So it means it's an important entity actually. So we have to keep this in mind too. Okay, another important point, because most of the time aortic stenosis is overlooked. That's why for me as an imager, those two illustrations are very important. One of them, the first scenario is you have an aortic valve area less than 1 centimeter square, but your mean gradient is less than 40. Your ejection fraction is normal, but your stroke volume index is equal or less than 35 milliliter per meter square. In this case, we speak about paradox love flow love gradient aortic stenosis. Generally, those patients are more than 70 years old with typical symptoms with no other reason. And they have generally left ventricular hypertrophy, decreased left ventricular longitudinal function without any other reason. And they have a mean gradient, generally mean gradients between 30-40. Aortic valve area is generally less than 0.8, and stroke volume index is less than 35. But keep in mind that this stroke volume index should be confirmed by LVOT measurements, confirmed by 3D TOE or multi-slice CT or CMR or by invasive data. And if we are sure about that, so we go to the calcium scoring by multi-slice CT. If we have, for males, if we have a calcium score more than 3,000, and for female, a half value, almost half value, 1,600, we can talk about severe aortic stenosis. It's very likely. But if it is for males, if it is less than 1,600 and for female less than 800, then generally it's unlikely. The other scenario is we have again a mean gradient less than 40 millimeter of mercury, and Vmax is again less than 4 meter per second, but our calculated aortic valve area is again less than 1 centimeter square. So why is that like that? Did I measure it correctly? If yes, we check it, and if yes, of course we go to the stroke volume index again. And if it is less than 35, if it is less than 35 again, and if your ejection fraction is this time less than 50%, then it means we have to go with a dobutamine stress echocardiography. And with the dobutamine stress echocardiography, if your mean gradients go up above 40, and if your aortic valve area remains less than 1 centimeter square, then it means it's a real aortic stenosis, severe aortic stenosis. But when you have a mean gradient more than 40, Vmax is more than 4, is it always severe aortic stenosis? Of course, no. You have to exclude high flow status like anemia, hyperthyroidism, and AV shunts, and so on. And if yes, if one of them is there, if it is reversible, then we have to reassess at restored normal flow. If it is not reversible, then it's again severe aortic stenosis. If you don't have a high flow status, it's severe aortic stenosis. So in 2012, in the guidelines, valvular heart disease guideline, it was saying intervention may be considered in symptomatic patients with low flow, low gradient aortic stenosis and reduced EF without flow, meaning contractile reserve. It was class 2B/C indication level. So, but in 2017, it changed, and it was saying intervention should be considered in symptomatic patients with low flow, low gradient aortic stenosis and reduced EF without flow, contractile reserve, particularly when CT calcium scoring confirmed severe aortic stenosis. It was upgraded. It went up to class 2AC indication level. What else do we check in echocardiography for those patients? Of course, we check left ventricle, right ventricle dimensions and functions, accompanying aortic regurgitation. Because if we have a, for example, if we have a moderate aortic regurgitation, and if after the procedure we have mild to moderate paravalvular leak, this patient can compensate this situation. But if at the beginning the patient has no aortic regurgitation, but after the procedure, let's say the patient has mild to moderate aortic regurgitation paravalvular, maybe this patient could get decompensated. So it is important. And we, of course, we check other valves as well, because if we have multiple valve disease, if the patient may tolerate the operation surgery, then maybe we have to give the patient to the surgery, because now we know that we are performing, so it's now recommended to do it for the moderate and even low risk patients. And annulus to coronary ostium height is very important. Cuspis length is very important. If your cusp length is longer than annular to ostial distance, then you have an occlusion risk, of course. And we have to keep in mind that we can measure the RCA height on transthoracic echocardiography, whereas you have to measure your left main height on 3D TOE or multi-slice CT. And another important point is basal septal hypertrophy. You have to warn your interventional cardiologist about septal hypertrophy. It's very important for the deployment. And left ventricle thrombus is very important. You have to warn your interventionalist, and septal bulging is similar. What about TOE? It's a debated topic actually, but our center, or experiences, we generally prefer doing TOE before the procedures. But those patients are fragile patients, and in some papers it is recommended better not to do a TOE, because those patients have higher risk for any kind of interventional procedures, and TOE is also like semi-interventional technique. And another important point is the anesthetic drugs. I personally prefer not to give any sedation, and it is also what is recommended. We generally use topical anesthetics, and because those patients are prone to hypotension, and they can collapse with anesthetic drugs. So we have to be very careful. And even if the patient cannot tolerate, maybe we can skip this part, or if we want to do it, if we are not sure about the aortic root anatomy, if we are not sure aortic annulus dimensions, and if there is a suspicion regarding cusp number, and so and if, for example, the most important indication of the TOE is if the patient, because those patients are old patients with low GFR level, so sometimes it is contraindicated to perform a cardiac CT. And in this case, we have to perform a TOE, a 3D TOE, to measure the annulus correctly, adequately. I generally do it. I do it routinely because I want to compare it with CT, because CT images are not always perfect. There are sometimes artifacts, sometimes we are not sure. So I'm checking everything, other valves as well. I'm checking if there is also other significant valvular heart disease, and I check everything with TOE. And of course, in the short axis, we see the aortic valve opening better, calcification, if it is central or eccentric, and if the localization, where is the localization of calcification, how is the severity, symmetry. We can see everything much better. But of course, we can compare it with cardiac CT. But if we cannot do a cardiac CT, I definitely do do a TOE and the 3D TOE for the measurements. And this is how a 3D TOE looks like. This is from a Philips software, and you can. This is the MPR method, multiplanar reconstruction, and if we find two long axis views, we can obtain a short axis view, and we have to be perpendicular to the aortic annulus, and then if we provide in both images that we can see the short axis view of the aortic valve, and if 3 leaflets of the aortic valve diminishes at the same time, it means it's the annulus, and of course we measure the short axis, diameter and the minimum and maximum diameters, and we calculate the mean diameter, and also we measure the perimeter and area, and we do the same for the sinus of Valsalva and the ascending aorta as well, and sinotubular junction as well. Another important thing is if we cannot perform a cardiac CT to those patients, of course, coronary height is very important, and we can see the coronary arteries in 3D imaging, 3D echocardiography, very similar to cardiac CT data. And if the image quality is good, then our 3D image quality is also good. We can say that. And a practical tip could be if the coronary artery is going to upwards, it's generally RCA, and if it's going downwards, it's generally left main, and we measure it from this annulus to the lower part of the coronary ostium, and the coronary height is should be at least 10 millimeters, but in some papers it says if it is less than 12 millimeters and the sinus of Valsalva is less than 30 millimeters, then the coronary occlusion risk is getting increased. Of course, those were everything was preprocedurally imaging, but intraprocedural imaging is also very important. I can say that we are not performing a TOE routinely during the procedure, but just before the procedure. And after we finish the procedure, we use transthoracic echocardiography. And I can tell you that, for example, what do we check? How do we need during the procedure? We check if it is underdeployed, because it's really important. If the valve is underdeployed, much regurgitation can get worsened, and we can also have a paravalvular regurgitation. If the valve compresses the AV node, we can cause a conduction disturbance, like complete AV block or something like that, and we have also late embolization risk as well. And but I think the worst scenario during a TAVR procedure would be a hypotension, a resistant hypotension during the procedure. Why do we have that? It is not a simple thing to decide on that, because some reasons are detectable with echocardiography, but some are not. We have to have a checklist during the procedure, and we have to think very quickly, because the patient doesn't have a time. One of the most important features of this procedure is it is not as difficult as, let's say, for me, I mean, as I observe, I decided that this procedure is not as difficult as, let's say, a matriculated procedure. This is this looks like a simple method, but if it has a complication, let's say a hypotension, we have to be very quick, and it's not very much imaging dependent. I'm speaking imaging wise, it's not very much imaging dependent, but if we have a complication, the imager has a big role, because sometimes we exclude, we detect the reason of hypotension with echocardiography. But as I told you, we have to have a checklist, and we have to act very quickly. Sometimes it's retroperitoneal bleeding. Sometimes it's pacemaker-related reversible stunning. Sometimes it's twisted left ventricle. And we have a list of periprocedural complications of transcatheter aortic valve implantation, which are accessible by echocardiography. What are those? Aortic prosthesis misplacement, and it can embolize towards the aorta or left ventricle. It can go here or upwards. And diploid valve is if it is too high positions towards the aorta or too low, as I told you previously, or if we have a central or paravalvular regurgitation for some reason, and if we have a mitral regurgitation, if the aortic prosthesis impinges here on the anterior mitral leaflet, or if there is a left ventricle asynchrony caused by right ventricular pacing, or if we have new left ventricular wall motion abnormality, which can be an indicator for an acute coronary ostial occlusion, which can be possible, which can be caused if we have a low coronary ostium height from the annulus, or if we have a small sinus of Valsalva, as I told you in the previous slides. And of course, cardiac tamponade. We can perforate left or right ventricle, and dissection or rupture of the aortic root. This is the last one is something really mortal, and this is caused generally by the subannular calcifications, and with severe forms of that. And we have to be very careful if we have a subannular calcification. And
so
one
Dr.
of the
Ozkan, please,
yeah.
I wouldn't like to interrupt you, but I'm getting some questions from the YouTube from Dr. Kafirov. He's asking, first he's saying that the lecture is very nice and he's enjoying it so much. Hatem Suleiman is sending his regards, Fadi Aziz, Abdullah Maghrabi, and all your friends. So we are happy to have them all with us watching this lecture and joining us on board. So Dr. Pervez Kafirov was asking you about the stroke volume index that you said less than or equal to 35 milliliters per meter square. How do you calculate it on the transthoracic echo, and how do you calculate it with the CT or CMR? This was one question. And then I will pass the mic to Dr. Karim because he also has a couple of questions for you.
Okay. Let's start with the first question. It's a very nice question. Thank you for the question. If I need to go back to that slide, this one. Yeah, it's very important for love flow, love gradient, and paradox love flow, love gradient patients. Yes, I generally practically calculate it with echocardiography, and we have a formula. I generally use an automatic online formula, and we generally put VTIs and heart rate and everything, and it calculates automatically. But what is suggested is, of course, if we will say it's paradox love flow, love gradients, aortic stenosis, it has to be actually confirmed by LVOT measure, by 3D TOE or multi-slice CT or CMR or invasive data. It is very simple to calculate it with CMR because it also gives it automatically, but I can say that it is not very common to do a cardiac MRI to an aortic stenosis patient, but I can say that I can use it more and more because I know that in my last slides I will speak about cardiac MRI, and we can also utilize this technique. It is not very much used, but I can say that it can be used more and more for those things and also for other things I will tell.
Thank you so much. Dr. Karim also has a couple of questions.
Thank you, Dr. Ozkan. It's fantastic presentation. Let's highlight some details. What about, we know that gradients, whether the peak or the mean gradients, are essential in the assessment of the severity of aortic stenosis pre-procedure. In some patients, we encounter difficulty in assessing these patients. Do you have some tips regarding assessing the gradient with, let's say, transthoracic echocardiography or transesophageal echocardiography for better defining the severity of aortic stenosis?
You said with TOE, and what else did you say? I couldn't hear.
Transthoracic TE, transthoracic or transesophageal.
Oh, okay. I generally do it with transthoracic echocardiography, but if not possible, I try it with TOE, because I do TOE routinely for those patients, as I told you, if there is no absolute contraindication. And if I cannot get it, I do it with TOE, but I can say 90% of the patients I can do it with transthoracic. Another thing is sometimes I try to do it subcostal. Sometimes when I do it subcostal, depending on the anatomy of the patient, I obtain a better image quality and I become more perpendicular, more aligned to the aortic axis. So sometimes I do it subcostal, sometimes I use very different angulations. It depends on the patient. And if I cannot do, I go to the TOE. If we cannot do, of course you can use invasive methods, which I don't prefer. Now I can say that after I also deal with cardiac MRI, I think cardiac MRI is one of the best methods to assess gradient and everything. And it's very accurate and simple.
Yes, that's a very good point. So you can use some other views such as subcostal, right parasternal,
Yes.
suprasternal views.
Yeah.
It's sometimes difficult, but it can be helpful in transthoracic echocardiography.
Yes,
In the
definitely.
transesophageal echocardiography, we can obtain the transgastric view
Yes, yes.
during the study to obtain the gradient across the aortic valve.
Yes, that's true. But to be honest, I can tell you that those patients are really very fragile.
Yes.
And I try to not disturb them too much, to be honest. I
Because
just
you do it without sedation. You do it with a topical
yeah, without
anesthesia.
sedation, transgastric is not very easy. I can say that. So I'm just trying not to disturb them, not to put them into stress. So
So we have the other views with the transthoracic, maybe the transesophageal, but we have the invasive measures with the through the catheter or the cardiac MRI. We
Yes.
can obtain the severity. Okay. What about the sizing and getting the data with the or the transesophageal echocardiography? Did you do that in some cases without doing multi-slice CT, let's say,
Yes.
when the patient is
Karim, yeah, that's a very good question. I can tell you that if I'm saying in 80% of the patients, I do a TOE. Sometimes the patient doesn't want it. Sometimes they have some problems with swallowing. And so I don't know, some contraindications for TOE, or sometimes they are very frail. Sometimes I don't do, but in most of the case, I do a TOE. But if I cannot perform a CT, I definitely go with a 3D TOE and do all measurements with 3D TOE, all aortic root measurements. And I can tell you that I compare all my measurements with CT, because most of the time they have both of them. I compare them, and most of the time they are very similar if you are accurate. If you are very precise and meticulously measuring, they are really very, very close to each other.
So your message here, still the CT is a gold standard, but in the expert hand with the transesophageal echocardiography, we can perform it in the some sizing and the calculation in some patients. My last question before letting you to continue this very interesting presentation. What about the other etiologies such as a bicuspid valve? What your parameter you looking for other than the usual parameter in the patient with bicuspid aortic valve?
First, we have to be aware of this definition. Sometimes it's functional bicuspid aortic valve. And most of the time, I think in the older population, we have this functional bicuspid. It's normal, not a bicuspid, but it's getting bicuspid because of the calcification and fusion with degeneration. So sometimes it's real bicuspid. And I can tell you that there are many papers on that, and there is not a certain consensus on the measurement of bicuspid aortic valve. And the calcification and, it is not very symmetric. And the other thing is there are actually 3 measurement methods. You can do a normal annular sizing or supraannular sizing, which is also sometimes recommended. And intercommissural distance is also sometimes recommended. So we actually try to measure all of them, and sometimes you are doing balloon sizing.
Yes.
It depends on the patient, and we just combine and harmonize all measurements and try to find the most accurate one.
Okay, thank you. So if we have no more questions, you can go with your presentation, please.
Okay. I think we were here. Okay. And I just wanted to emphasize this suicide left ventricle because it's also not very well known. I actually learned it in 2016, to be honest. I didn't know that before that. But after some cases, I just wanted to learn what is happening to the patients with small LV and diastolic diameters, preserved EF, significant left ventricular septal hypertrophy, high AV gradients, and small overall LV mass. Those patients are at high risk. And, after valve deployment, there is a marked reduction in ventricular afterload, producing improvements in ventricular myocardial energetics. So, those combinations with improved ventricular contractility, at the end we have a cardiac shock and hypotension resistant one, and we have to be aware of this entity, this phenomenon, and this is very dangerous. The treatment is removal of exogenous inotropes and suppression of endogenous catecholamines, and fluid administration and vasopressor use as treatment. Sorry. And what about the follow-up after TAVR procedure? It's after you do the procedure, you have to follow up the patient, and after 1 month, after 1 year, and every year, each year, we have to assess the patient clinically and echocardiographically. Of course, we have to assess many parameters, and what can we see? We can encounter a degeneration, for example, if there is an increase in the mean gradient, if it is more than 10 millimeter of mercury, and if there is a decrease in effective orifice area by 0.3 or 0.4 centimeters squares, and we have to think about degeneration. And with echocardiography, we can see calcified, thickened valves, and also we can, if we are not very sure, we can also verify it with cardiac CT as well. That's why multimodality is important for us. And we can also see thrombosis, and if we have a diffuse or focal hypoechoic thickening more than 2 millimeters, and for the thrombosis, generally more than 1 leaflet is affected. Its incidence is variable. It's between 4 and 40%, and echo may overlook this thrombosis. Patients are most of the time asymptomatic, and for the patients who are not symptomatic, if there is no symptom, multi-slice CT is not recommended for the routine follow-up to check if there is thrombosis or no. And if there is no symptom, no increase in the gradient, anticoagulation is not recommended for those patients. And another important thing is, and it's a big concern for all of us, if we see an increased transvalvular gradient, it is very first of all, it's very important to report the immediate after the procedure gradients, because afterwards you will compare them. And if there is a decrease in the effective orifice area in comparison with the reference study, and if you have a reduced leaflet mobility, if you have a leaflet thickening or calcifications, if your DVI is less than 0.35, and if you have a rounded CV Doppler jet, if you have all of those things, you have to be suspicious for a valve dysfunction, and a CT or a TOE may confirm the etiology. If you don't have none of those, you have to check your measurements. It can be contaminated by mitral regurgitation jet. If it is not, so you have to go to this box again. And if you don't have a decreased effective orifice area in comparison with the reference study, and if you have a sinotubular junction less than 3 centimeters, you have to think of pressure recovery. If you don't have that, and if your effective orifice area index is less than 0.85 centimeters square per meter square, you have to think of moderate or severe patient prosthesis mismatch, which can also be the case in fat patients with a small annular size. Or if you don't have that, you have to, of course, think of high output like fever, anemia, and significant aortic regurgitations or AB shunts and thyrotoxicosis and so on. And valve-in-valve is another topic, and valve is important because it causes generally a higher gradient, as we all know. And for the sizing of valve-in-valve procedures, if we have the size of previous, let's say, surgical valve, and if we are sure about that, we can use that size. And if we don't have it, what can be used is the internal diameter of the valve, actually. Let's move on. And one of the most important things is paravalvular leak. Why is it important? Because it has been shown many times in different studies that a significant paravalvular leak is an independent predictor of mortality. So for us, paravalvular leak is very important, but it is not very easy to assess paravalvular leak. First, because of the acoustic shadowing of the native calcification or prosthesis stand, it sometimes has multiple jets, and it is sometimes irregular in shape. So it's not something simple, I can tell you. And this illustration shows us a simple way of understanding the localization of the paravalvular regurgitation. This is done for, this is illustrated for transthoracic echocardiography. And if we have a regurgitation at around 12 o'clock and 6 o'clock, we have to go to parasternal long axis view. It's like that. If we have it around 3 o'clock and 9 o'clock, we have to use the apical fourth chamber, and we will see it here. If we have it around 1 o'clock and 7 o'clock, it's in the apical three chamber view. This is a little bit vice versa, because this is a TOE image, but I can show you something. Just a second here. It's like that. Let's turn into let's make it upside down. It would be then 6 o'clock position, and in 6 o'clock position, like that, it's like between mitral aortic junction, and it's really between mitral junction, in the mitral junction. So okay. And what are the clues of severe paravalvular regurgitation? Of course, it's very similar to the native valve aortic regurgitation, short PHD, pressure half time, and if it is less than 200 seconds, then we have to think of a severe paravalvular regurgitation. And if we have multiple jets, and if we have a holodiastolic flow reversal in descending aorta like in normal native valves, and if in the short axis view we have extension of more than 30% with color Doppler, then it's also suggestive of severe paravalvular regurgitation. And what are the good prognostic factors during the follow-up periods? If we have an increase in ejection fraction and global longitudinal strain, and if we have a decrease in end diastolic volume and pressure, and if we have a decrease in E to A and E to E prime ratio, if you have decrease in right ventricular dimensions and increase in right ventricular functions, if you have decrease in systolic pulmonary artery pressure, then those are good prognostic factors during the follow-up period for a TAVR patient. And we said we will speak about multimodality imaging in TAVR procedure. CT is, some of you know, CT is really my favorite imaging modality with its high resolution, and everything is very clear, but the only concern is radiation, of course, and the contrast medium. But it shows everything really clearly. But for the sizing, I will not go step by step because it's a big, important other session, I can say, the sizing with CT, but I will give you some tips and tricks. Sometimes I see, and there are some mistakes with measuring. If you are measuring like that, like freehand tool, with the freehand tool, if it's like that, it's not, if it is not smooth, then it can overestimate the aortic annulus area and perimeter as well. So we have to be very careful. And with polygon method, it is also not recommended because it's also not very accurate. But if you use the spline method, it's like already smoothened. It has to be like that. It has to be manual place segmentation points connected by a cubic spline interpolation, like elastic ruler. And it has to be like that. It has to be smooth for an accurate quantification of annular perimeter. It's very important point. And of course, there is a grading for the subannular classification. It's like mild, moderate, and severe. Sorry. If we have a single non-protruding focus, then it's mild classification, like that. If we have two or more nodules, protrusion, but the protrusion is restricted to annular and the subannular region, then it's moderate. But if we have single or multiple annular calcification, which are protruding into the lumen and extension to the alveoli, then this is severe calcification, and it is very much associated with subannular rupture, which is one of the most mortal complications of this procedure. This is very important. If you will remember something from this presentation as an imager, I would say that for me, this is maybe the most important part of my presentation, because the subannular calcification, especially the severe ones, if you see that, you have to warn your interventional cardiologist. And if you have a hypotension during the procedure, in your checklist, you have to put your subannular rupture, aortic rupture, to the first line, to my opinion. And of course, one of the other important things is paravalvular regurgitation. In many trials, in many studies, it has been shown that when you have a paravalvular regurgitation, most of the time you have a subannular calcification. And this is what we measure during a normal diagnostic algorithm. Of course, we measure the annulus with a couple of maneuvers. We obtain the annulus. We measure maximum, minimum, maximum and minimum diameter, and we also calculate the mean diameter, and we measure perimeter area, and we also add perimeter derived diameter, and we have many measurements. One of the most important measurements is corneal heights. This is very similar to 3D TOE, as you can appreciate. If you have a good image quality, 3D is not inferior to CT, I can tell you. And of course, the resolution of CT is not debatable. It's very good, but of course, if you cannot do it, and if you have a good 3D image, it's comparable. I mean, you can do also 3D. And the height of sinus of Valsalva is also very important. This is the sinus of Valsalva. In the sinus of Valsalva measurement, of course, we have 3 measurements from each cusp to the commissural point. We have 3 measurements, and we have to give all of them. And this is sinotubular junction, and here. And also, we have ascending aorta calculations, and we have. It is very important to be parallel to the annulus annular level, and otherwise we can really make mistakes. So another important thing which we can understand with cardiac CT is the differentiation of differentiation of thrombus and pannus formation. It is not easy to differentiate with echocardiography and clinically, and with TOE transthoracic. It is not always easy to differentiate pannus from thrombus, and of course the treatments change, and that's why it's very important to make an accurate diagnosis at the end. And we can utilize cardiac CT in that case. It's about Hansfield unit, and if we have a thrombus, as you can see in this nice table, it's very simple. If we have a thrombus, it's most of the time less than 90 Hansfield units. But if you have a pannus, it's generally in the papers, it's determined like that. It's more than 145 Hansfield units. We can differentiate it with that as well. And of course, you have to use clinical clues as well. It's not only like that, but of course, clinical evaluation is also very important. And those are my last slides, and those are one of my favorite slides, I can say, because it's again multimodality and about cardiac MRI. Cardiac MRI is a very nice method as well. It has no radiation, but I can say that the resolution of cardiac MRI is not better than cardiac CT. Cardiac CT is on the top in terms of resolution. Cardiac MRI is very good because we have no radiation, and we can also perform it in patients with chronic kidney disease as well, to some extent, I can say. And it is more useful in those patient groups. So how do we use cardiac MRI? For which aim? First of all, for the determination of severity of aortic stenosis, as you have already asked, and I have already answered, if, for example, we cannot be sure about the severity of aortic stenosis, about the gradient with TOE or with transthoracic, and we don't want to do an interventional invasive method, so we can determine the severity of aortic stenosis with flow study, with velocity encoded phase contrast flow, CMR quantification. We can calculate the gradients and Vmax and the mean gradient, maximum gradient, and everything. And you can also, at the same time, calculate regurgitant fraction. And you can also appreciate, you can also understand how much aortic regurgitation you have, how much accompanying aortic regurgitation you have, accurately, very accurately. And of course, another thing is if you use non-contrast high resolution 3-dimensional CMR of the aortic root for valve sizing, you can calculate, for example, your annulus size with cardiac MRI as well, and the coronary height as well here. And there are also some fantastic methods like real-time MRI guided TAVR. I've never seen, I've just read a couple of times, but I really would like to see. And quantification of paravalvular aortic regurgitation is one other important issues, because as I've told you, with transthoracic echocardiography and with TOE, it is not very easy to determine the grade of paravalvular regurgitation because of the reasons which I've told you previously in the previous slides. And but with MRI, with cardiac MRI, we can very accurately and reproduce with high reproducibility, we can calculate the paravalvular aortic regurgitation. So it's a very useful method. We can also see the other vessels for the access side. And another thing is we can assess the ventricular remodeling, we can quantify the myocardial injury, and we can see the advanced myocardial tissue characterization. Another thing is, let's remember the stroke volume index. You have asked also. We can also calculate the stroke volume index for paradox, low flow, low gradient, and aortic stenosis, which is recommended to do. And of course, if we speak about MRI, not cardiac MRI, MRI, we can see also brain with diffusion weighted MRI to assess for cerebral lesions caused by emboli during TAVR procedure. And I want to show you something more. For the paravalvular leak assessment, if we have a regurgitation fraction less than 20%, if it is mild paravalvular regurgitation. If it is between 20 and 40, it is moderate, and if it is more than 40%, it is suggestive of severe paravalvular regurgitation. We are just marking it like that, and it is an automatic program. And if you press the button, it makes it forward, and we simply calculate the regurgitation fraction and gradients and Vmax and everything about aortic valve. And it's a very simple method. In 2 minutes, you can give everything. And this is, sorry, this is my favorite topic among all. This is the role of fluorosity during TAVI procedure. I don't use fluorosity just for TAVR cases, but actually for all interventional procedures. As a structural heart disease imager, I think fluorosity will get more and more bigger roles in the near future. This was a case of us, and we are planning to publish it soon. It's already written, and it will be the second case in the literature. And we had a patient with which was referred to us from another center with a severe paravalvular regurgitation, and you can appreciate with transthoracic echocardiography how severe it is. And this was a short axis view. We of course performed the TOE, and you can appreciate the PHT. It is like 148 milliseconds, and it was a severe paravalvular leakage. So this patient was already performed the TAVR procedure. That's why the patient had already a CT. And we wanted to utilize this cardiac CT and retrospectively. In this image, in TOE, you can appreciate that the leak is just on the left side of the interatrial septum. This is a TOE view, and it is like approximately 60 degrees beyond the interatrial septum. And in this case, we just wanted to go back to cardiac CT, and we found the interatrial septum in the short axis view, and we imagined that it is approximately here, and it is actually corresponding to a calcified commissural part, which is possible here. And of course, we did some maneuvers, and in the CT you have three squares in front of you, and if you adjust in two images your alignment, you will lateralize your localization where you want to go. And in this image, we lateralized in our mind and on CT the possible defect localization. It should be here, somewhere here. And we wanted to see on fluoroscopy the same image, and it was approximately like that. And we went to the similar angulation as much as we could, because it is not easy to get the exact angulation, but it was very close to that. And in this case, we imagined that if we sent the wire in this angulation, if we sent the wire towards the left side of the aorta, if you bend it to the left side of the aortic wall, then it should cross the defect directly. So it happened, really. It happened. And after we crossed the aortic arc, it took only 12 seconds to cross the defect. And it reduced the amount of contrast medium in a very old patient. And of course, the radiation exposure for the patient and for us it took only maybe 15 minutes, the whole procedure. And we put a VSD closure device. My prof extended it, and we closed the defect. And you can appreciate here how it was closed. The device is here, and we closed the defect very easily. And of course, this is also an example of utilizing multimodality imaging. It's not only one imaging modality. We have to imagine. We have to be creative, and we have to use that, and we have to combine in our minds, in front of us and everywhere. It's all for the patients. Our aim is to find the most accurate information about the patient for the best treatment. And I want to remind all of you that cardiac imagers are the eyes of the heart team. Thank you for your attention.
Thank you so much, Dr. Ozkan. This was very nice, and actually, congratulations for yourself and for Omar for making the great closure for the paravalvular leak. Also, this is really a very nice case to be reported. Karim Mahmoud has a couple of questions, and Professor Adel Azmi has a couple of comments also. So Karim, maybe you can pass your questions to Ozgi, and then we will pass the mic to Professor Adel to give us his insights about this section.
Thank you so much. It was really fantastic. We learned a lot from you today.
Thank you.
I believe we have a lot of data regarding the second part on the role of the CT and the whole description of the aortic valve and sinus of valve ascending aorta. I think you also mentioned the role of CT in assessing the whole length of the aorta and the access to obtain an idea about the iliofemoral axis, which is suitable, and how to use it. I'd like to ask you about, as Mohammed mentioned, there are different valves that are commonly used, which are the self-expandable and balloon expandable valve. Are there CT data that favor the use of either valve of them? And if we use, let's say, a balloon or expandable, does the sizing differ regarding the CT if we use the self or expandable valve?
Yeah, it's a very nice question. We, in our daily practice, in our clinical practice, me and my prof, of course, he is much more experienced than me in the field, and we decide on the valves and everything together with him and with our heart team. And if, for example, we have a sigmoid septum, especially a sigmoid septum, we tend to choose Cepheum valve, Cepheum 3. I don't know what is your experience on that. I really wonder your experience as well. And also for the subannular calcifications, we also tend to use that. So, but for the sizing, no, for the sizing, it's always the same. We do the same sizing. It doesn't change. We do a normal CT sizing. But of course, for different valves, there are different charts, and we go to the charts and we decide on, sometimes sinus of Valsalva is important, sometimes something else is important. And we speak with the companies as well, and we sit together and decide on everything together.
So it depends upon the whole information, the diameter, the perimeter, the heights, and the sinus of Valsalva.
Yes,
we
everything.
Combine all these data to obtain the optimal size of the valve that we should use.
Yes.
Okay. Do we have any comment from Zahran or Dr. Adil or Haytham? Dr. Adil?
Adil, I would like to take his insights also, because I know that he has a very big structural heart disease program in King Fahd complex currently. So I would also like to learn from his expertise, and we have the opportunity of having Ozkan also between us tonight. So Professor Adil, the mic is yours.
Yes, thank you very much for this elegant and extensive educational lecture. I enjoyed the handmade cartoons and the handwritten algorithms that you made. This proves that you are really not only a non-invasive, a good doctor, but also a very elegant teacher as well. Thank you for that. Yes, you proved also that it's a teamwork. We cannot, the importance of non-invasive imaging before the procedure cannot be overemphasized. And you have elegantly illustrated it's an integral function of both the transthoracic, the transesophageal, the CT, as well as the MRI. As you said, it's not only deciding the size, but also the importance of obstructing the coronaries. So you deal with each case individually and then decide on the size and the type of the valve that can be implanted. Also, you have divided it into pre, intra, and post-procedural. So we know the function of the echo and the other modalities in determining, especially the early anticipation of post-procedural complications. And this will allow you to rapidly intervene and give your recommendation for the interventionist to interact. Thank you very much. Thank you.
You're welcome.
So much,
I think now it's Karim, the lecture of Karim.
So currently now we will have Dr. Karim Mahmoud. Dr. Karim will show us a case presentation from real life scenario for a patient with severe aortic stenosis. Maybe I would like this case to be presented by Dr. Karim, and Dr. Ozkan, feel free to interfere whenever you think that something in the imaging needs an explanation or needs some tips and tricks regarding this particular case. So please go on, Dr. Karim Mahmoud.
Thank you, Mohammed, and thank you again, Ozkan. This is a heart failure patient that I first met in the outpatient clinic. And the heart failure is not so easy as we will see to diagnose, to know the precipitating factor, to know how to improve the symptom of our patient. This is a 60-year-old male. He has a mitral valve replacement 5 years ago before presentation. and probably due to a mitral valve disease due to aromatic heart etiology. He is known to be hypertensive. However, his blood pressure on presentation was controlled. He's compliant to his medication, as we will mention later. His problem started 1 year before presentation with recurrent hospital admission with heart failure functional class 4, together with rapid attacks of rapid atrial fibrillation. In between the admissions, he is severely symptomatic. He has severe exercise intolerance with shortness of breath, functional class 3, and he reported that his ejection fraction was 35% in April. So to start, this is his ECG that showed atrial fibrillation. The rate is more or less controlled and about 90 to 100 beats per minute, not so rapid, together with the left bundle branch block configuration. His X-ray showed cardiomegaly with evidence of pulmonary congestion. So we are in outpatient clinic and we see this initial investigation. So we thought about these causes. We might have a mechanical valve dysfunction such as a paravalvular leak, thrombosis, pannus, etc. Severe systolic dysfunction, severe LV systolic dysfunction, coronary artery disease, arrhythmia, and rapid tachyarrhythmia. Non-cardiac causes such as anemia, thyrotoxicosis of chronic kidney disease, or other causes of worsening of heart failure. So we, to somewhat exclude the atrial fibrillation, as the rate, as I mentioned, was 90 beats per minute. It's not so rapid, so atrial fibrillation might be not the cause of his heart failure symptoms. We revised his echocardiography done last year. He's had an ejection fraction of 35%, as we mentioned, with dilated left ventricular dimension. The mechanical mitral prosthesis was well functioning and with acceptable gradient. He has aortic valve disease with a mean gradient across the aortic valve of 23 millimeter mercury. He has also a severe tricuspid regurgitation. It's functional, it's not organic, with estimated pulmonary artery systolic pressure of 55 millimeter mercury. So again, we revised our causes and we excluded the mechanical valve dysfunction. Actually, the mitral valve was well functioning, and we don't have any cause to suspect that the possibility of heart failure is due to the mitral valve dysfunction. So it might be due to a severe systolic dysfunction with this poor ejection fraction, or maybe another causes. More revision of his investigation. He has a coronary angiography 1 year ago, and he has a PCI to a stable lesion on the second obtuse marginal with a severity of 60 to 70% stenosis. And actually, 9 months later, he has another angiography that showed patent stent. So we excluded a coronary artery disease as a cause of his symptoms. His laboratory were normal regarding the kidney function, hemoglobin, mild anemia, but nothing serious, normal thyroid function, and no other lab abnormality. And actually, he has a good INR of 2.5 to 3, and he was compliant on warfarin. So non-cardiac causes excluded. We are left with a severe systolic dysfunction or other cause that precipitate the heart failure. And these were his medication. He was compliant to warfarin, clopidogrel, sacubitril valsartan, 100 milligram twice, carvedilol, amiodarone, furosemide, a large dose of furosemide of 125 milligram with IV diuretics during the hospital admission, and spironolactone. So heart failure medication is more or less good. So severe systolic dysfunction could be a possibility. However, we opted to search for other causes of his heart failure. So this is his echo 1 year ago, and this is his echo now. We can see that we have a severe impairment of his overall systolic dysfunction. This is not 35. This is lower than 35. We had a mechanical prosthetic valve, and we have aortic valve disease with a reduced excursion of the aortic valve. So we have also a mild to moderate degree of aortic regurgitation. Actually, it's a moderate degree of aortic regurgitation. This is aortic valve in the short axis view, and we can appreciate the severe LV systolic dysfunction in the apical four-chamber view.
So, Dr. Karim, allow me to interrupt you here because
Sure.
I think this was one of the scenarios presented by Dr. Uzge. You have a gradient that is below 40 millimeters mercury. So you look at the other parameters, you look at the ejection fraction, and you find that the ejection fraction is impaired actually. So most probably the left ventricle cannot generate a proper gradient across this valve, and you need to perform a test, maybe like a dobutamine echo, to allow this ventricle to strengthen itself up and generate a gradient across the aortic valve. And maybe this is going to be proven later on to be a severe stenosis if the ejection fraction improved while the aortic valve area remains small or the same, and the gradient across the valve is increased. What do you think, Dr. Uzge, about this ejection fraction and this pressure gradient?
Unmute yourself, please, Dr. Ozje. No, still you.
You need to unmute yourself.
Yes.
Oh, yeah.
Yes.
The problem is I couldn't hear for some reason what you were talking about. Can you please repeat the question? Technical problems.
Okay.
So Muhammad raised the possibility
a low ejection fraction.
Yes, low ejection fraction. Yes.
And the pressure gradient is 23 only across this ejection fraction. So
yes,
probably this is one of the cases, scenarios that you elegantly showed us in your drawing.
It's most probably like a low flow, low gradient aortic stenosis, right? You thought also so?
So we thought about that. We have actually.
Have you performed a dobutamine stress echo, or?
Yes, I mentioned that later because we have a marked reduction of ejection fraction over this 1 year from 35 to less than 20%.
Okay.
Together with the persistent symptoms of heart failure despite good medical treatment, and then the presence of aortic valve disease as we saw in the transthoracic echocardiography.
Okay.
So we thought about the low flow, low gradient aortic stenosis as a cause of this heart failure worsening and persistent symptoms.
Yes.
And we opted to do a dobutamine echocardiography to confirm or exclude this possibility because it would change markedly the management from a medical treatment to the possibility of intervention for these patients.
By the way, it's also very important to emphasize that after aortic stenosis patients develop a heart failure, then it is like the end stage. I mean, it's most probably the patient will die soon. So you have to do whatever you can.
Symptomatic treatment is also a prognostic treatment for this patient. Actually, I totally agree.
Yes.
So as you mentioned, Dr. Ozje, it's very important to exclude or confirm the presence of aortic stenosis. So we opted to do dobutamine echocardiography, and the results were marvelous, were astonishing. We have an increase of the mean gradient from 15 to 38 millimeter mercury. This is the parameter. The peak systolic velocity increased from 2.4 meter per second to 4.1 meter per second, with an increase in the mean gradient from 15 to 38, and improvement in the ejection fraction from 17% to 38%, in the presence of the fixed aortic valve area of 0.9 centimeters square. So, so you agree that is on the diagnosis of low flow, low gradient aortic stenosis?
Yes.
Okay. So this is a rule of heart team. We have this significant aortic stenosis, and of course, with a high incidence of mortality due to general condition, heart failure, low ejection fraction, and actually the calculated Euro score 2 is 20%, depicting a high surgical mortality. So the surgeons choose not to operate this patient, and we choose to do a TAVR for this patient. We should remember that this patient, the etiology is mostly rheumatic, which is reported as case series and case report in the literature, rather than a large trial on doing a TAVR for a patient of rheumatic aortic stenosis. Do you agree, OG?
Yeah, I agree.
Yes. So I'd like you to comment on and the difference on of the aortic valve on the CT due to a rheumatic etiology and the calcific etiology. Do you think this is a calcific etiology or another etiology such as a rheumatic etiology?
Are you asking me?
Yes.
Okay. Actually, I would expect also some more fusion here. We can appreciate that the valve is thickened. Yes, that's true. We can see that black borders of the valve. We can see also some tiny calcifications. But to be honest, I would expect more fusion in these parts of the valve for a rheumatic valve.
Okay.
To my opinion, this looks more like degenerative to me. I'm not sure if the patient has, for example, a drug history or I don't know.
No,
because
not
the patient is a young patient and
it's a 60
yes.
years. However, he has a mitral valve disease.
Yeah, accompanying mitral valve disease as well.
Yeah, he has a prosthetic valve due to
okay.
a mitral.
Okay, and is it a typical rheumatic mitral valve?
We are not sure because we don't have the preoperative data actually. However, it's not due to an ischemic heart disease.
Yes. Okay.
And the most cases in due to that operated with mitral valve in our country is due to rheumatic heart disease.
I understand. Yes, that's true. Most of the time, if the patient is young in countries like Egypt, in Turkey, in the developing countries, we see lots of rheumatic valve disease. That's true. But my only concern was I would expect more, as I told you, more. Here the commissural fusion is typical for the aortic valve disease. So this is the first thing. But if, for example, this is not a rheumatic valve, it could be also something like drug-induced at this young age, or another thing could be like radiation exposure at this young age. If the patient has, for example, a radiation exposure to the chest, both valves would be affected as well, just to keep in mind for the other patients, I mean.
Okay, thank you. So to you, the etiology is not very clear from the CT image. Maybe
yes.
The degenerative
If we want to decide just from this image, of course it's not very typical, but if of course it's not only CT data, that's why echo and the clinical history and everything is important in all patients.
Okay, thank you. So as you mentioned in your illustrative lecture, our CT imager took all the diameter, the maximum and mean diameter of the aortic annulus. Then the mean diameter was estimated to be 20.6, and the perimeter is 85.8. It's between.
Yeah, I'm interrupting you, Karim, because here in this example, for example, this is like done with polygon method, okay? And we want it more smooth, actually. Okay, yes. Not like that, more smooth. That was what I'm talking about, actually. But of course, it looks okay. But for the most accurate one, it has to be smooth.
Okay, I appreciate that. Yeah, thank you for this comment. So it's about 26 diameter, and the perimeter is about 85. This is a chart of the volute R that we choose to select to do this patient. And again, the measurement of the sinuses valsalva and the sinotubular junction. Then the measurement of the tubular ascending aorta. Here we felt that we should have a good distance between the aortic annulus and the mechanical mitral prosthesis, the LVOT, because if we have a short distance and the aortomitral continuity is very short, this may encroach on the mechanical mitral prosthesis. The height of the left main and the right coronary were accepted, especially the left main was 12.4 millimeter. And the peripheral axes, the descending aorta, and the iliofemoral axes were actually acceptable. Here we can appreciate we don't have a much calcification, and both sides are acceptable. We choose the left side because it has a less tortuosity. Also, we have an assessment of the coronary artery. He has a nearby coronary angiography. However, we assessed the coronary angiography and it was fine. And of course, the stents cannot be completely assessed with the CT angiography. However, the impression it was that the stent is patent. The LED and RC also were patent. So regarding the TAVR data, the procedure was done under general anesthesia because this patient is high risk. This patient was in heart failure, and he has a hypotensive episodes with the week before the procedures. And during the induction of anesthesia, he has a hemodynamically unstable white complex tachycardia on induction. He has he received cardioversion immediately and returned to his baseline risk. His access was through the left common femoral artery through a surgical cut down, and the right common femoral artery was used for big tail catheter for the control injection, and we used also the right common femoral vein for the temporary pacemaker wire. And this is the procedure. This is the big tail in the for doing the aortic angiogram, and this is the coplanar images in the for the obtaining the three cusp at the same line. We can appreciate the well-functioning mitral prosthesis with adequate excursion of both occluders and the presence of the transvenous wire of pacemaker. Here we use the ambulance left catheter for passing the wire with a straight wire, and we achieved the passing the wire through the ambulance left catheter, exchange to the ambulance super stiff wire for giving the better support to the valve to pass. As we can appreciate here, this is the passage of the valve through the descending aorta, the arch till or crossing the aortic valve. And here we try to adjust the valve, putting in mind not to go so deep into the LVOT. And we starting the release of the valve. Actually, in that image, we felt that the valve is going so deep, so we recapture the valve again and adjust its position. And this is a control angiography before the point of no recapture. And lastly, this is the release of the valve. The control angiography was fine with no significant aortic paravalvular leak. No peripheral complication was confirmed after the closure of the site of surgical cut down. And the valve were stable on the last cinefluoroscopy, as you can appreciate, with adequate excursion also of the mitral occluders. Echocardiography showing the valve is stable. there is a mild or increase in the LV systolic dysfunction, as we can appreciate in this echocardiography. Actually, the ejection fraction rose from 17 to 27% on the immediate follow-up. There were no aortic paravalvular leak. Here, the M mode is not so accurate. However, we obtained the biplane Simpson method. It was about 27%. The valve was good, actually, and the mitral prosthesis also was good. The gradient across the mitral prosthesis was acceptable. And we have a mean gradient across the aortic prosthesis of 4 millimeter mercury. Post TAVR procedure, we have immediate weaning from the mechanical ventilation and IV vasopressors. And actually, we give IV fluid with no worsening of the heart failure, guided by CVD, of course. No evidence of heart block, so temporary pacemaker was removed. So this patient had a wide complex tachycardia twice. It was a ventricular tachycardia. He received an additional doses of amiodarone. This time, there is no drop of blood pressure and no evidence of myocardial ischemia. This was his VT. And the VT was cardioverted was cardioverted successfully with no dangerous consequences. And this patient in the future might need an ICD. We discharged him and let him for the follow-up on this medication: warfarin, clopidogrel, sacubitril, valsartan, carvedilol, amiodarone. And we markedly reduced the dose of diuretics for this patient and spironolactone 25 milligrams. So to conclude, we searched thoroughly for the cause of heart failure in this patient, and we tend to have aortic valve disease that causing heart failure worsening. And as you mentioned, Ozgi, aortic valve disease and heart failure carries the worst prognosis. TAVR offers a practical solution for high-risk cardiac patients, and it's a multidisciplinary approach, and the key of success is a good preparation. Thank you so much.
Thank you so much, Dr. Karim, for this great case presentation. Dr. Ozgi, do you have any comments about this case?
Yes, thank you for this nice case presentation. Sometimes we have similar cases, and my suggestion for imagers, especially imagers, because I think those are game changer people, because we have sometimes patients who came to our clinic for an ICD implantation or CRT implantation. And when we perform a careful echocardiography, if we see a calcified aortic valve with an ejection fraction of 20, let's say, we shouldn't leave the patient. So if we have, let's say, a mean gradient of 20, we shouldn't say it's a degenerative valve and the mean gradient is just 20, 25. So we have to be very careful if we are really suspicious of a severe aortic stenosis, which could actually be the reason of worsening of the cardiac function. So if we change this situation, if we treat the aortic stenosis, the patient maybe will be automatically, if he or she has a reserve, contractile reserve, the situation will completely change. And the patient maybe will not need an ICD or CRT and nothing. And we had such cases, actually. That's why I'm emphasizing that situation. We had such experience. And after we put the valve, sometimes we did it urgently. Sometimes we did it emergently. Sometimes the patients had cardiorenal syndrome, and we even couldn't do a hemofiltration because the blood pressure of the patients were going immediately down with loss of consciousness of the patient. So we did sometimes emergent TAVRs, and it changed the life of the patient immediately. So we have to decide on the disease as imagers, because whatever we tell to the interventional cardiologist, he does it. I mean, if it is a severe aortic stenosis, first we have to solve this problem. If it is not severe, so we have to put an ICD, but it very much depends on the imager. So it is a very big responsibility. Whenever we see a calcified aortic valve, we have to be very precise. We shouldn't do that echocardiography in 10-15 minutes. We have to focus on the aortic valve. We have to do our best for a higher and higher and higher gradient. If we cannot obtain, and if we have the criteria for love flow love gradient or paradox love flow love gradient, we have to know these two definitions very well. We have to calculate stroke volume index simply with a formula online. And if those two definitions are there, so it means it's severe aortic stenosis, and we have to treat first the valve. Thank you.
Thank you so much, Dr. Uzgi, for these valuable comments. Professor Adil Azmi, also I would like to hear from you, dear Professor, your insights and comments about such a case presented by Dr. Karim. Sir, are you there?
Yes.
Thank you, sir.
Karim, thank you very much for this nice illustrative case. The way that you made the diagnosis by exclusion of other causes of heart failure was really very good, and arriving at the final conclusion of low flow, low gradient aortic stenosis and proving that. And then the procedure, it's like you said, a bailout procedure that succeeded to change the life of the patient, at least partially ameliorating the need for intensive diuretics and getting him out of heart failure. I have a question for you and a question for Dr. Ozkan. For you, the timing of removal of the TPM, because some centers remove it immediately if you don't have widening of the QRS complex. And some centers, including our center, we wait for like 48 hours because edema around the conduction system might develop later on. This is my question for you. And for Dr. Ozkan, is there any special consideration in imaging regarding the bicuspid aortic valve, special images or special consideration, the type of the valve that would you implant, and the special considerations for the apparent origins for the coronaries? These are my two questions. Thank you very much.
Thank you, Dr. Adil. This is very good point. And there is also different practices regarding the removal of temporary pacemaker wire. However, we remove the temporary pacemaker wire after 24 hours if we don't have any conduction defects or heart block. So as far there were no a few patients that need pacemakers, and we saw that during this duration that if we have a danger of heart block, it will occur within this 24 hours. But however, I think it's differ by the center and your protocol to prolong the duration to 48 hours. Also, it's respected and it's more conservative.
Thank you.
So, Dr. Uzgi, please, about the bicuspid aortic valve, Dr. Adil's question.
Yes, I answered this question before. It was a similar question, but of course I will extend my answer a bit. First of all, in terms of imaging, as I told you, there are different types of measurements with CT. We can measure annular sizes, and we can do a supraannular sizing, and we can also measure the intercommissural distance. Those are three recommended measurements actually, and there is not a consensus yet, I can tell you. And we in our daily practice combine all of them and try to find the best size for the patient. And another thing was I told you about the balloon sizing. Of course, it's not the first line sizing method, but of course it helps. And the other thing is there has been some studies on this bicuspid aortic valve patients and with newer generation balloon expandable valves. And but of course there is no rule about it, and no established rule. And what else? The important thing is we know that bicuspid aortic valve patients are generally younger. And another concern is the durability of those valves. If the patient is a little bit younger and if the patient has if the STS score or Euro score is not very high, so in those patients, maybe we can decide on the surgical method with our heart team. Yeah, my concern is always the durability actually, because we don't know the very long-term results of those valves yet, but of course we will see. What else? Another important thing is if this is a congenital bicuspid aortic valve, of course, we have to keep in mind that congenital anomalies are always accompanying to each other. So this is another point now. And if the patient has a bicuspid aortic valve, first we have to keep in mind that this patient might have another congenital anomaly first. And we can appreciate that with echocardiography and with cardiac CT as well. This is the first point, especially aortic coarctation. Independent from the age, we can see we shouldn't miss, we shouldn't overlook those pathologies. The other thing is coronary anomalies, and those patients could have some coronary course or origination anomalies, and we have to keep this in mind, and we have to approach to those patients in that way. Those are special patients actually.
I'd like to add two more points, Dr. Ozgi, if you allow me.
Of course, please.
The presence of severe aortic regurgitation in this patient would make the intervention of this patient, I think, really difficult, and
yes.
The stability of the valve would be markedly affected.
Yes,
and another thing that another point that the aortic with the bicuspid aortic valve, we commonly have an dilatation, the aortic annulus and the aortic root. So if we have the dilatation above the limits for the valve, the TAVR procedure would not be suitable for this patient.
Yes, definitely, I agree. Thanks for adding that.
Thank you so much, Dr. Karim, for presenting this very educated case. And thank you so much, Professor Adel Azmi, for moderating tonight's session with us. We're taking a lot of your time and your effort, but you are so generous, and we are really honored to have you with us tonight. Of course, our guest of honor tonight, Dr. Ozgi, thank you so much, actually. Everyone on the YouTube, we have more than 154 attendees up till now. They are all saying thank you so much. Fadi Girgis, Abdullah Al-Maghrabi, Hatem Suleiman, and all your friends are watching us, and they are saying thank you so much for this wonderful presentation.
And thank you also, Zahran, for your nice presentation.
Yes, thank you, Mohammed.
Thank yourself.
Thank you all. I'm very glad to be a part of this team, and I'm very glad to have everyone on board with us tonight. It's beyond midnight now in Istanbul, and Dr. Ozgi probably sleepless, so I would not make that longer. Thank you everyone that attended with us tonight, and all our viewers from all over the world. Next Saturday, we will be discussing the congenital heart disease, the single ventricle part 2, which will include the imaging and the clinical scenarios. On Tuesday, we will finish the bifurcation webinars by the trifurcation and quadrifurcation also. This will be a very nice webinar, and I'm preparing a couple of nice cases, one with a trifurcation and one with a quadrifurcation for the left main. And next Thursday, we will be discussing the prophetic valves. We will have some cardiac surgeons on board with us, so we can take the views from the cardiologist as well as the cardiac surgeon, and we can be applying the heart team discussion on the CEC channel also. So thank you again, everyone, and hopefully we see you next week in the best shape and the best health. Bye-bye.